I think we have a decent quorum, so I'm going to go and get started. So I'm going to ask Dr. Watt to introduce our grand round speaker.
Good morning, everyone. I'm honored to introduce Dr. Francis Pagani, who is the Otogago Professor of Cardiac Surgery at the University of Michigan. Dr. Pagani's clinical focus includes surgical therapies for advanced heart failure, including heart transplantation, mechanical circulatory support, among other clinical interests. Dr. Pagani has an active research program supported in part by the National Heart, Lung, and Blood Institute, an agency for healthcare research and quality. His research focuses on the translational development and testing of mechanical circulatory support devices and clinical health outcomes research. He's an excellent mentor with many other accomplishments and accolades, but insisted on keeping this short. So without further delay, I welcome Dr. Pagani.
Thank you, Tessa. Appreciate it. And really, it's an honor to be presenting to the group. I'm going to try a little different. I tried to bring my presentations up to the 21st century and try to make them a little multimedia. But let's see how this goes. But I'm going to talk a little bit about. Let me bring up my talk here. Here we go. And I'm going to speak a little bit about really the history of mechanical circulatory support and where we are today. And please, if there's any questions, please feel free to raise your hand and we can discuss.
So Frank, we can't see your presentation. If you think you have it up, we're not.
Okay. All right. Well, then I have to share it. Hold on a second. How's that? Can you see my desktop now?
Yeah, we can. Go ahead, go down there and hit the, what you call it, to make a big presentation. There you go.
How's that?
Perfect. Thank you.
So I'm going to start off with a little presentation on the history of sort of mechanical circulatory support and where we are today. And really the focus of this talk is on durable mechanical circulatory support, so implantable devices that are really meant for long-term support from months to years. And this talk will not focus on short-term circulatory support devices such as ECMO or other percutaneous devices. So there's really the history of mechanical circulatory support for durable devices really had two paradigms. One paradigm was really championed by Dr. Denton Cooley, and the other was by Michael DeBakey. And really what these paradigms involved was, one, a consideration for total cardiac replacement or utilizing total artificial heart technology. And the other paradigm is really cardiac assist, leaving the native heart in place and using mechanical circulatory support to assist device. And two clinical really events occurred that really supported, potentially both of these paradigms. The first was Dr. DeBakey's use of an extracorporeal or paracorporeal device implanted following an aortic valve replacement where the patient could not be removed from cardiopulmonary bypass. And Dr. DeBakey used a pneumatically driven pulsatile device that was connected to the axillary artery and drained the left atrium. And the patient was supported successfully for 10 days, and then the device was removed at the bedside. And the patient lived many, many years afterwards. And this really was really a validation of the approach to try to use mechanical circulatory support to assist the heart. Prior attempts were also successful, one by Dr. Adrian Kantrowitz and another by Dr. Crawford, were similarly supported the concept of ventricular assist. Really, I'll let you see this. This is the first use of the total artificial heart for a bridge to transplant application performed by Dr. Denton Cooley. And I'll let you watch this a little bit.
An orthotopic cardiac prosthesis is shown beside the excised heart. The atrial portions of the prosthesis are uppermost. The rod cutter hingeless valves are positioned between the prosthetic atria and ventricles. Similar valves are in place at the entrance to the dacron tubes, which subsequently will be connected to the aorta and pulmonary artery. Cardiopulmonary bypass was discontinued. Circulation was maintained in a satisfactory fashion. Heparin was later counteracted with protamine sulfate.
This event really spurred development for the use of the total artificial heart technology as a bridge to transplant. And is supported by the National Institutes of Health development program at that time, and millions of dollars were shuttled to this program. What occurred next was really the use of the total artificial heart technology as a permanent replacement. And many of you are familiar with the notoriety of these attempts. This was Dr. Barney Clark, who underwent replacement of his heart with a total mechanical heart replacement performed by Dr. William DeVries in 1982. And there was a few more attempts by Dr. DeVries to utilize the total artificial heart as a permanent replacement without much success. Actually, Barney Clark passed away approximately 100 days or so after the implant. And a more famous implant was that of William Schroeder, who survived actually 660 days of support, but suffered many strokes and many complications during the period of support. And I think the concept of the total artificial heart as a permanent replacement was really abandoned in the mid 80s. The work continued by Dr. Jack Copeland, utilizing this technology as a bridge to transplant, but that received much less notoriety. Really, what was transforming this space was the use or development of devices for cardiac assist. And there was really, in the early 80s, two groups. One was the group that, this is Pierre Portner, who's an engineer who developed the NovaCore device. It's a pulsatile device, electrically driven. And this device was implanted as a bridge to transplant successfully, first done in 1984 by Dr. Oyer at Stanford University. And this was validating the concept of utilizing partial assist as a bridge to transplant. A second team similarly was developing a device, a electrically activated device called the HeartMate device. And the lead engineer was Victor Poirier from Thermocardia Systems at the time. And Thermocardia Systems was eventually purchased by Thoracic that developed the HeartMate line of devices. But these early attempts really, I think, validated the use of cardiac assist for bridge to transplant applications. There was a pivotal study performed in the early or mid 1990s that really sealed the use of these devices for this application. And this was a trial led by Bud Frazier from Texas Heart Institute, and they utilized the HeartMate technology, the XVE device, you can see here, as a bridge to transplant. And this was really an important landmark trial, because what it did, it established two important observations. One, that the use of this technology improves survival to transplant. So if you look at the graph on the left-hand side, you can look at the survival of patients in the dark line who received this device waiting for transplant. So that looks at their waitlist survival. And that was compared to a historical group of patients with receiving intravenous inotropes or aortic balloon pumps. But more importantly, what the trial demonstrated was that survival after heart transplantation was significantly improved by the use of these devices compared to patients that were transplanted on balloon pump or inotrope support. And this, again, based on this work and work from the NovaCore applications, both these devices were approved for bridge to transplant application in 1998. And so both these trials demonstrate the feasibility of implantable LVADs to support the circulation until transplant, and demonstrated both improvement in survival to heart transplant and in post-transplant survival. Now, the next major question was, could these devices, these assist devices, be used as a viable alternative to heart transplantation, or could they be used as permanent therapy? And this important trial was championed by Eric Rose from Columbia. And this was a clinical investigation of the use of the HeartMate XVE for permanent application. And this trial was called the rematch trial, or the randomized evaluation of mechanical assistance for the treatment of congestive heart failure. And this was a very significant trial that was initiated in the late 1990s and early 2000. And really the important finding from this trial was that the use of mechanical assistance, the HeartMate XVE, doubled survival compared to patients who were on inotrope support. So if you look at the survival curve to the right, you can see that the survival of patients at 1 year was approximately 55% compared to about 25% for medical therapy. So there was an important doubling of survival time with the use of mechanical assistance. But one of the important observations from this trial was that mechanical assistance was fraught with a lot of complications, particularly with this device. Device reliability was very poor, and approximately the median durability of these devices were approximately 12 to 18 months after implantation, and most patients suffered mechanical complications of these devices. Now, this is our first patient that we put in the rematch trial. This is Thomas Mader, who was actually quite a real advocate for the therapy, and he lived 5 years with the therapy, but required 5 pump replacements to do so. So it demonstrated feasibility of survival, but really the mortality and morbidity of this therapy was pretty significant. Then in the early 2000s, a technological breakthrough really occurred, and most of you are aware, understand that, and that's the use of continuous flow devices. These devices really were applied and had a significant advantage of mechanical reliability and mechanical simplicity, and they really transformed the space. And this is an early experience with the use of the HeartMate 2 device, which was an axial flow device, a continuous flow device with axial design. And this was first reported in the early 2000. And really the important findings from this clinical trial were that the mechanical reliability of these pumps were far superior to pre-existing pulsatile pumps. And then in this trial, we saw a durability or freedom from pump replacement of almost 90% at 1.5 years compared to about 50% with the prior devices. The next logical question that arose from this successful application of the rotary devices for bridge to transplant application was, could these devices be utilized for permanent therapy? And what we demonstrated then was in the HeartMate 2 pivotal trial for destination therapy, we saw again a marked improvement in survival with these devices. And so in the blue curves, you see the survival of patients. The top line is utilizing the HeartMate 2 continuous flow LVAD. And the blue line below that is a randomized comparison to the HeartMate vented electric device, the pulsatile flow device. And you can see an improvement in survival of about 50% at 1 year to about 70% at 1 year for the continuous flow devices. And in the gray lines below that, you can see the actual curves from the prior rematch trial. So again, the overlap of the two pulsatile survival curves from the pulsatile devices, one representing the use of those devices in the rematch era, and still, almost 10 years later, the pulsatile devices still had a survival similar to that in the rematch era. But you can see the improvement in continuous flow survival with the continuous flow devices. And this was an important stimulus for the use of mechanical circulatory support for permanent therapy at this time. So, what we demonstrated with that trial was, one, there was incremental improvement in survival with the new technology, and really significant improvement in the durability and mechanical reliability due to the design of those devices. The next logical question that came up in the course of the therapy was, because of the improving outcomes, could we use mechanical circulatory support as an alternative to medical therapy in treatment of less advanced stages of heart failure? Typically, patients that were undergoing mechanical circulatory support implantation at the time were inotrope dependent and very sick and had some degree of multi-system organ failure prior to undergoing device implant. And so the thought of this trial design was really to attack earlier stages of heart failure before end-stage organ dysfunction set in. And this was a trial that was developed, or a program that was developed by the NIH and led by Dr. Tim Baldwin and Dr. Mann to develop a paradigm for the Revive It pilot trial. And this was the randomized evaluation of ventricular assist prior to inotrope therapy. And the program project or contract was actually awarded to the University of Michigan, and we began a series of evaluations and study design to evaluate this hypothesis that devices could be used to treat earlier stage heart failure. Unfortunately, we ran into a number of problems with the technology. One, after several years of clinical use, it became apparent that the HeartMate 2 axial device was plagued by a number of problems, particularly device thrombosis, largely because of a more robust experience. The rate of thrombosis became really apparent in clinical use that wasn't apparent in the clinical trial experience. And you can see here that after 2000, somewhere around 2010, as the device technology became more disseminated, there was a recognition that device thrombosis was an important limitation to this device. And because of that, it received, the Revive It trial received a lot of negative press and ultimately led to its termination. And so the hypothesis, although the hypothesis remains that mechanical circulatory support is potentially treatable for less advanced stages of heart failure, we haven't had device technology that we felt suitable to test this hypothesis. Now, around that time, however, more newer technology arrived on the clinical arena. And many now, you're all familiar with the HeartMate 3. And the HeartMate 3 was actually revolutionary technology. And it brought to the field a concept change in terms of how blood was handled in terms of the design and blood flow. So rather than using an axial design, this pump used a centrifugal design. But more importantly, the impeller that spins within the pump was levitated by a complete magnetic field, so that there is actually no touching, there's no bearing wear or no touching of the impeller to other mechanical areas. Importantly, the use of magnetic levitation allows large gaps between the walls of the impeller and walls of the pump housing. And so this device ended up having some very unique features that led to its really approval for use for destination therapy and for bridge to transplant applications. And in the clinical report of this trial, which completed in 2019, one of the really remarkable aspects of this device was a 5-fold reduction in the need for pump replacement due to pump thrombosis or pump hemolysis. And this has really led to a dramatic improvement in survival. And you can see in the lower figure, if you look at a composite outcome of freedom from pump replacement, survival, or a debilitating stroke, the centrifugal pump or HeartMate 3 device performs superior to the HeartMate 2 or axial device. But what was really unique about this device, and if you look at subsequent data from registry data from the INTERMACS report, you can see that in survival following clinical dissemination as in a real world registry, you can see that the use of this device has led to incremental improvements in survival. But more importantly, when we look at survival now, early stages of survival with this device, the device survival is now on a par with heart transplantation in the early, at least for the first 3 years of support. So we now have a device that is comparable, at least to heart transplantation, for 3 years of support. And so this has been a remarkable achievement in terms of technological development. Now, more importantly than just survival is cerebral vascular events. And so if you look at stroke has been a major limitation with all this technology. When you look at freedom from stroke with the HeartMate 3 technology, you can see, and this is evaluation from the INTERMACS registry. This is a recent report by Cho and colleagues. You can see that the HeartMate 3 has superior freedom from stroke compared to the HVAD, which was a competing device, a centrifugal flow device in the market. And now to be able to say that patients have about a 5 to 6% stroke risk at 1 year compared to what was existing in the field before is a pretty dramatic improvement in the technology. Importantly, if you look at, and I think this curve nicely demonstrates really the progress that has been made over the past 20 years. So the bottom curve, in yellow, represents medical management in the REMAX trial. And that was the early testing. And you can see just above that is the survival that we experienced in the REMAX trial with the HeartMate ventiloelectric, the pulsatile device. And now over a course of 20 years with technological improvements, we actually moved to a point where now we have technology, at least for the first 2 to 3 years, now competes with heart transplantation. Now, when you look at some of the studies that are done by heart transplantation in terms of the DCD donors, and you look at the outcomes reported, the risk of stroke for heart transplantation is not benign. And so one of the comparisons that really needs to be made with mechanical assist is the risk of stroke between mechanical assist and heart transplantation. A recent report looking at DCD outcomes compared to use of hearts from brain dead donors, there was a 5.7% risk of stroke in the 30 days after heart transplantation in that trial. So stroke is an important consideration. And so it seems like from both survival and stroke risk comparatives, that the early results of mechanical assistance seems to be as good as transplantation. Despite the really dramatic improvement we've seen in mechanical circulatory support in the last few years, adoption of mechanical circulatory support has really not been well developed. And you can see these are data looking at the number of implants in the INTERMACS registry. The INTERMACS registry is a device registry its participation is mandated by CMS, and all devices that are durable devices that are implanted in the United States that are not part of FDA trials are included in the registry. And you can see that device use has plateaued about 3,000, about similar levels to what transplantation is in the United States. And if you look at recent, there's been a fall off, a pretty significant fall off in device use. And that is likely due to two factors. One, that's likely due to COVID, but more importantly, there's been a change in the heart allocation system that no longer prioritizes durable mechanical circulatory support. So in prior eras, mechanical circulatory support was prioritized on the heart allocation and used as a way of bridging patients to transplantation. Durable mechanical circulatory support has now lost that prioritization and is no longer seen as a viable option to bridge to transplant. And that is debatable. But its use has dropped off because of that. And if you look at the number of patients that are undergoing implantation of a durable device for bridge to transplant application in 2021, where our most recent data exists, only about 7% of durable devices are now being used as bridge to transplant application. And nearly all uses of this device now are for permanent application. If you look at the device development over the years, there's been a number of devices that have been brought to clinical use. Today, there's only one durable device that has been that is FDA approved for use. And the device development is quite difficult. Each of these devices was in clinical use in the United States, either during FDA testing or in clinical application and then removed. And each of these devices had a number of limitations that resulted ultimately in them being removed from the market. More recently, after 20,000 implants, the HVAD device was a decision by Medtronic was made in June of this year to remove the HVAD device from the market. And that largely stemmed from data from the INTERMAX registry that demonstrated a marked improvement in survival with the HeartMate 3 device over that of the HVAD device, and the marked improvement in freedom from stroke for the HeartMate 3 device over the HVAD device. So now we're left with one single device in the market, the HeartMate 3, but this device has demonstrated significant improvement in outcomes. In summary, the device engineering and development is very complex in this field. As you can imagine, and trying to develop a device that is implantable, reliable, and can support a patient for a decade or more. We've had some outstanding, stories here. We currently have someone on continuous mechanical circulatory support with one HeartMate 2 device that's going on 14 years. And so extended support with these devices is feasible, but it is labor intensive, developing these devices, and it is expensive. And in order for this therapy to be widely disseminated, we need to reduce the adverse event burden and make these devices less costly. There is, however, been meaningful progress in reduction in stroke and reduction in a number of other adverse events, particularly mechanical malfunction. Devices are much more reliable today than they have been in the past. But as I said, the dissemination of these devices remains quite limited. And so the overall epidemiological benefit to the number of patients that have heart failure remains limited today, and wider dissemination is needed, and important barriers remain. Now, what does the future sort of hold? So there's a number of devices in clinical testing today. The one is the Everheart. And that device, some of the superior blood handling capabilities of that device are touted to reduce gastrointestinal bleeding events associated with this therapy. CH Biomedical is a device that has been brought by a Chinese company and developed in China. And the one feature of this device is also its blood handling capabilities, and is touted to be similar to the HeartMate 3 in outcomes with a reduction in bleeding events. The important aspect of this device is it's touting to be half the cost of what the HeartMate 3 costs. So it might bring an important reduction in the cost of therapy. The CoreWave device is actually an interesting device being developed by a French company. And this device actually uses a novel way of creating blood flow. Rather than a spinning impeller, a centrifugal or axial type of impeller, This device uses a vibrating membrane similar to a speaker, a loudspeaker, and that can actually be turned on and off to create pulsatile flow. And so this is an early device development and hopefully soon to be in clinical development. Now, the next device, I think, really tries to include all the features that I think are necessary in order to bring this therapy to a less ill group of patients with heart failure. There are certain principles that we need to really utilize. One, these devices have to be implanted through minimally invasive techniques. That's an important concept. Two, they have to be reliable. Three, the devices really have to use total implantability, meaning that they need to eliminate the percutaneous lead or driveline that is typical of current devices that acts as a communication between the implantable device and the power source that is located outside the body. And so this film sort of emulates all those principles. One, through a less minimally invasive incision, device can be implanted without the use of cardiopulmonary bypass. This device can be then inserted into the heart, and it lies right underneath the aortic valve, positioned underneath the aortic valve and used for assist. Now, a implantable controller is then placed. It's hooked up to the EKG, so now it's synchronized. And now the external transcutaneous power source is then utilized to transmit power to the system. And so with an internal battery, someone could remove that and actually shower or swim and still have power for several hours a day in the system. This device, termed the Fine Heart device, is being developed by a French company and is now in advanced stages of animal testing, but may undergo early stages of human implantation next year or the year after. But I think the critical elements of this device are that it's minimally invasive implantation without cardiopulmonary bypass and totally implantable device design. Now, the story of the total artificial heart is not over. There has been an effort to bring forth continuous flow technology to total artificial hearts. This effort has been led by an engineer, Daniel Timms, there pictured on the left from Australia, and William Cohn, or Billy Cohn, on the right, is a surgeon from the Texas Heart, and Bud Frazier, who've been really proponents of this device. This is a very small device with continuous flow technology, and it potentially could revolutionize the field. Early testing with this device has been very promising, and it's been uniquely designed to accommodate most patient sizes, and it has extensive reliability. So hopefully we'll see clinical testing of this device that could potentially transform the space of total artificial heart replacement. This is a totally implantable device, so again, it will have no percutaneous lead and potentially support patients for decades. So despite over 2 decades of modest success, the mechanical replication of human biology is really a profoundly humbling journey. There's been a number of pitfalls and failures, but have important success. We now can support patients with survival that rivals transplant in the early years, and actually has a freedom from stroke that rivals transplant in the early years. And really, the greater adoption of durable mechanical circulatory support will depend on technology advancements. Each of the major milestones in improvement in survival have come with a development of technology. So the improvement of the HeartMate 2 over the HeartMate vented electric, and the improvement of the HeartMate 3 over the HeartMate 2 have come with really important clinical success. And I'll leave with one of my mentors and dear friends, Bud Frazier.
Anything is not so much the heart transplant.
I think that sums up our hope with this technology, but clearly much more work is needed in the field, particularly with device development, to realize some of the visions of some of the prior pioneers. Thank you.
Thank you very much, Frank. We really appreciate you coming and imparting all your knowledge on us. We've been very fortunate to have you on our faculty for the last 25 years. And we want to thank you for all the great contributions you've not only made to the field, but to our university, and how proud we are to say that you've been my partner for many years, and you're a colleague, and the program that both you and Keith put together is actually amazing. And we're very, very grateful and proud of you, both of you.
Well, thank you, Mike. Those are very kind words.
So Frank, it's Gaurav. So again, thank you for that outstanding overview and timeline. And once again, you've been so embedded into what Michigan cardiac surgery is, and of course, led the path really in the nation. So thanks for all your contributions. My question really relates to, really it's exciting to see this future of where it's going, and of course the progression, how we've gotten better with these devices. And if I were to ask you, what are the 3 most burning things or issues with VADs? I mean, I think we all have an idea, but I'm curious your thoughts, and how are these new devices going to tackle them? Whether it's thrombosis, whether it's bleeding, GI bleeding and lack of pulsatility, whether it's anticoagulation and stroke, battery, all that stuff. So I'm just curious what, as the expert, what are the 3 things that you think are really needed, and how close are we with these new devices?
Well, I think the major limitation now that prevents greater dissemination, I think, is represented by the percutaneous lead. I think the idea of batteries being carried on the outside, this has to be implant and forget technology. And unless it becomes implantable and forgettable, it's not going to be widely disseminated. So I think an important barrier remains the percutaneous lead. And so I think devices need to be designed that have an option for a percutaneous lead, because not all patients can reliably utilize a totally implantable device. But I think devices need to be totally implantable and utilize transcutaneous technology. That technology has been around almost 30 years. And there have been devices already that have been totally implantable. We just need to get this to our more reliable devices. The second point, I think, is really the interaction of biology in these devices. So you mentioned a number of important points of GI bleeding. GI bleeding is interesting because these devices induce a state of acquired von Willebrand's disease. They degrade the high molecular weight multimers of the von Willebrand factor and create a sort of platelet disorder. And so having devices designed, you see less of that in the newer devices, because they're designed with wider gaps and they're friendlier to the blood elements. And I think that is now being incorporated in device designs. And also our anticoagulation protocols are changing. We're now involved in a randomized trial with the HeartMate 3 device, where we're actually randomizing patients to aspirin or no aspirin, because we don't think that aspirin may not be needed in the setting of a ventricular assist device because of its effect on the von Willebrand's factor. So I think those are 2 important areas. Stroke continues to be an issue, I think, though, but with the current technology, I think we're almost there. I mean, the incidence of stroke in a class 4 population with atrial fibrillation is probably about 3 to 4% per year. And so now we have a device that's about 5 to 7%. So we're getting in the range of baseline, stroke rates. So I think we've made significant progress along those lines.
Frank, this is Jonathan. Thank you for this excellent talk, and I'll echo what Mike and Gaurav have said. Thank you for your leadership of our program. Thank you for leadership of the space. And also thank you for your mentorship of me as I've sort of tiptoed in these treacherous waters. I want to ask a question about economics of VAD therapy. You sort of touched on it when you mentioned that the high entry point for industry to get in the space and the lack of competition has potentially reduced some of the economic efficiency. But where does VAD stand in terms of cost and quality of life year compared to some of the other expensive therapies that healthcare has offered for patients?
So right now, the implantation and early costs of are similar to heart transplantation, but where the cost of LVAD therapy becomes more noticeable is in the follow-up period because of the readmissions. And so that really hurts the therapy. The initial cost, I think, is largely due to the device itself. But I think, as we see here, we may have a device that costs significantly less, and may that be a feature of that device. And so I think if we can get more competition in the market and reduce adverse events, the readmissions, then I think that we have a therapy that becomes, similar to transplantation.
I see Dr. Colvin has her hand up. Monica, please ask your question.
Sure. Thanks, Frank, for that wonderful overview. You touched upon the Revive It trial, and unfortunately, we had to stop and not answer the question of whether less sick heart failure patients could benefit from device technology. But I want to know, what do you think about still pursuing that? Do you think that's still a valid question? And if so, what do you think it would take for the community to have confidence again to implant devices in less sick patients, or at least to answer the question?
Well, two wise people told me that it's probably not feasible. One was Lynn Stevenson, and the second one was my friend Keith Aronson. Both said that, and the reason, in truth, the reason is that it's a surgical trial. You're offering surgery to one group and then not offering anything to, except not anything, but good medical therapy to another group. And it's really difficult to do a surgical trial where the randomization is to optimal medical therapy versus a surgical therapy. There's a lot of bias of the patients coming into the trial, wanting therapy. If they're so willing to enter the trial, they usually want the therapy. And it's a difficult trial to undergo. The other issue with doing that trial now is we're seeing a lot of competing therapies coming up. The transcatheter edge-to-edge repair, TAVR for high risk heart failure patients, ablations. We're seeing a lot of competing technologies that people are trying to utilize prior to considering mechanical circulatory support. And some of it's appropriate, some of it I would disagree with, but that's where the space is right now. So I think it's difficult to do that trial.
Keith, please go ahead.
Yeah, thank you, Frank. First of all, it was a spectacular talk. I want to thank you for the opportunities you've given me over the past 25 years. It's been a tremendous joy. I want to ask you about the Feinheart device, because it looks to me like there's a lot of stuff in the ventricle. What do you think about the problem with clots? Do you think that it will be okay?
Well, I'm not sure. My concern is that if you look at every axial design device that's been brought to clinical trial has failed, right? Every axial device, the DeBakey LVAD, the Jarvik LVAD, the HeartMate 2, the MVAD, and then the other one, the axillary artery Circulite, correct. Thank you. All those devices were axial devices that were plagued by pump thrombosis. So I don't think that axial flow offers, I think its risk is pump thrombosis. And so I think the technology really needs to be, what is demonstrated to be reliable has been magnetically levitated pumps. If you remember the Dora Heart pump was a totally magnetically levitated pump. It failed because of its bulkiness and other issues, but that pump was crystal clean in terms of pump thrombosis. 60 patients, we never experienced any hemolysis or pump thrombosis. And so I think that's where the device design needs to stay.
Thanks.
Dr. Pienta?
Hi, Dr. Pagani. So I had a question related to these really striking overlay of the Kaplan-Meier survival curve showing the remarkable progress over the last 30 years. And then contrasting that with the overall stable number of device implants over the last 5 years. Do you think there's a lack of awareness of the overall improvement in bad technology and improvement in outcomes? Or do you think the change in transplant allocation policy a few years ago favoring temporary mechanical circulatory support has really just pushed people who really want to get a transplant to skip that and trying to pursue a transplant? I'm just wondering if you could comment on that.
Well, I think there's a I think there's a perception that that the LVAD therapy is plagued by, it's not a perception, in some cases it's reality, but it's plagued by a lot of adverse events and readmissions. And so I think the greater dissemination is not occurring because of that issue. I don't think a lot of the field is aware of the current results. I mean, if you ask a group of cardiologists, not heart failure cardiologists, but general cardiologists, what is the risk of stroke on a HeartMate 3 device at 2 years? I suspect a lot of them would say 20, 30%. And, that's just not, that's not the case. And so I think there is some lack of knowledge of current outcomes, but I also think there's a perception that the therapy, rightly or wrongly, has a lot of adverse events associated with it. And I think that's why you're seeing a lot of alternative therapies being utilized first, because trying to avoid the use of mechanical circulatory support. I think, though, when we come up with a totally implantable device, implantable and forgettable, that I think then we could potentially make a challenge, a trial challenge to some of these other therapies.
Dr. Patel?
We naturally tend to gravitate towards people who make a big splash and stuff like that. But in my mind, a lot of times what they do is just empty the pool so that other people can't swim. Okay. The real people who actually make a big difference are the ones that will slowly fill that pool up and make sure that more and more people get to take a swim. And so the thing I'm trying to tell you is that at least what I've seen, and I got to know you, I think at the very beginning, right after you had published a paper, very seminal paper about how to use ECMO as a bridge to, to do cardiac surgery and transplantation a little bit better. And what I've seen subsequently is a lot of building bridges with people like Keith, people like Bob Cody early on, and other members of the faculty. I think the other part that I've seen is it's not just about the heart failure, LVAD population, but you've really helped a lot of people in this section actually learn how to take care of patients with really sick hearts and operate on them very, very safely. And all the while, building bridges with engineers from companies, educating many of us on faculty, as well as some of the residents that have come through, and partnering with other people throughout the CVC, people like Keith, to be able to build what is really a very, very remarkable academic program, something that emphasizes why cardiac surgery at Michigan Medicine is leaders and best, right? And I hope that everybody on this call recognizes what you have been able to accomplish in partnership with other people in this CVC and how you have contributed to this section, this department, and this CVC in the institution. So Thanks a lot, Frank.
Well, thank you, Manchu. I really appreciate that. And as I said, I think the collaboration that Keith and I have had has been really rewarding to me personally. So it's been a great thing. I mean, my saddest day was when Keith and I had to hand back the $17 million to the to the NIH, but that's okay. We got over it.
Yeah, I want to echo what Manchu said. I think our society is so bent on instantaneous gratification, and everybody wants transitional change. What they don't understand is transitional change is a culmination of incremental change. Many, many steps, a lot of hard work, a lot of setbacks. I think that, when I was talking to the applicants yesterday, and they said, what do you need to be a cardiac surgeon? And I said, you need to have courage. That's what you really need to have. You need to have the courage to be vulnerable and to step out into that unknown. And you have done that, Frank. And you've put yourself out there, and you've taken criticism, both you and Keith, but you continue to learn. And a lesson here, and you're a true pioneer, and true pioneers are not afraid to fail. And it's okay to fail, but it's not okay to learn from those failures, to move forward. And you guys have done that over the past 25 years. And we are grateful, and many, many patients and others are grateful. And you've left a legacy for many medical students and residents in our future.
Well, thank you, Mike. I mean, truthfully, I mean, a lot of what we learned was based on your early experiences that you and Steve had here. I mean, you started a lot of the mechanical circulatory support here and left us in a good place to lead from that. So thank you.
Other questions? I see, is your hand up again, Michael or Keith, or did you forget to take it down?
I just
If
forgot.
there are no other questions or comments, go ahead, somebody, Keith, anybody?
No, I forgot to take it down, but
Okay.
I want to thank all of you and it's amazing how Frank managed to give that talk without actually, just so greatly underplaying the role he had in all of this. I mean, so many of the things that he mentioned happening were things that he either had an enormous role in or completely drove himself. But that's part and parcel of who he is.
That is so true. When those residents asked me, I said, the other thing that you need besides courage is you need to be humble. And Frank's a great example of both of those.
You're here.
So if you have no other comments or questions, thanks, Frank, and everybody have a great day.
Thank you for the privilege. I appreciate it. Thank you.
Yeah, bye-bye.